Okay, this is a patient who has some hydronephrosis, renal stones, and this retroperitoneal mass. Any thoughts about the mass?
Is it a male patient, Aarti?
It is, yes.
Okay.
No, sorry. This is a female.
Okay.
There is a clue down here. Okay, I'm going to put it on bone windows.
Yes. Very dense bones.
Extremely dense bones.
Like mastocytosis or plasmacytosis? No, not plasmacytosis. Mastocytosis?
Mastocytosis.
It's not mastocytosis.
Myelofibrosis with extramedullary hematopoiesis.
Very, very close.
Okay.
So this is malignant osteopetrosis.
Oh, wow.
And then this retroperitoneal mass was extramedullary hematopoiesis.
Nice.
Yeah. So, I mean, normally when we think about a retroperitoneal mass, we can just talk about the differential. Common things are going to be liposarcoma. This one didn't have fat in it, although dedifferentiated has less fat. We can think about leiomyosarcomas of like maybe the gonadal vein. We can think about solitary fibrous tumors. And then, of course, like the Mets, like you were saying, is it a male patient? So could this be like a huge nodal Met from a testicular tumor? But the bones were the key, super dense bones. So I'm just going to bring over the Radiopedia article about it. So osteopetrosis, there's an infantile form that's more, patients may die in infancy. And then, but sometimes this one, they can, live to midlife. And then there's a kind of benign one that's more benign. They have extremely dense bones. They get a lot of fractures, because, where is it? They're due to chromosomal defects and defective osteoclasts, and therefore the medullary canal doesn't exist. The long bones are bulbous and have a metaphyseal flare, and then basically it leaves no space for hematopoietic tissue. So it's really common to have extramedullary hematopoiesis. And then another feature is that they often get like a lot of fractures. So yeah, that was just osteopetrosis with extramedullary.
How old was the patient?
In their 30s. Yeah.
Wow.
Wait, I want to show you one more thing.
I've never seen osteopetrosis in adults. That's cool.
This is an uncommon case. And they actually have a lot of dental issues because of the overgrowth of the bone. But another reason is that their sinuses are completely obliterated because of all this bony overgrowth. So they basically have no sinuses.
They also have tiny neural canals, so they have a lot of cranial nerve issues as well as spinal cord issues because of smaller foramen magnum.
Okay. This patient had a cholecystectomy and they were concerned for biliary, a CBD transection. There is a drain in place. This is what the biliary tree looks like on the T2. So when I first saw this, I was like, biliary transection, like you would think there would be a huge bile leak. I don't see any fluid here. But anyway, then the bilirubin was only like 3. So we decided to do an EVIST. And you can see this was like the 20-30 minute EVIST. EVIST abruptly stops right there. You can see it's being excreted in the kidneys. So we kept going. And by the 40-minute one, we can see the biliary trees even more. And then you can see that there's this big surgical drain. There's a bile leak. There's bile here. And then a lot of the eovist is actually exiting through the drain. Even some of it is leaking back along the skin. So it actually was, they like, basically it was like an 80% transection of the common bile duct. And biloma was not collecting because it was mostly being drained off by this large surgical drain. There was a little bit in this fluid here. I'm just going to show you the coronal. So basically here it was below the confluence. It was completely 80% transected, which is why I think that like it wasn't backing up. It wasn't like the bile ducts were completely obstructed, but it was mostly leaking and then tracking out into this drain. Oh, another cute thing in this case.
Dropped gallstone.
Did you see it?
Yeah, it was apparent more on the T2.
Yes, exactly.
Also on T2, if you see the posterior segments of the liver, they're more slightly hyper. So I don't know, like the segment 2 and 3 are the normal intensity, but 5, 6, 7, 8 looks slightly hyper.
Okay, what do you make of that?
I don't know, is the liver congested, edematous? Looks slightly brighter, or is it just...
Maybe, I don't know, but this is the drop gallstone. So anyway, to treat all of this, they went in and did a hepaticojejunostomy to fix that bile leak, and they also went and scooped out the drop gallstone.
I think you brought out a very important teaching point. I think we saw similar case couple of weeks back and did not see any myeloma and did not see much leak either. But there was clearly the drain was hyper intense on delayed phase, which means eovist was leaking outside. So seeing eovist in the drain itself is a telltale sign that there is some leak happening somewhere.
Yeah. And it's always really, really good to communicate with the team to see what their level of suspicion is. And they were like, bile is pouring out of this drain. We know there's a leak. We want to see what the level of the leak is. And we were like, oh, we don't see it, but we'll keep keep the EVA scan going. And then, we finally saw it. And then we were able to tell them, oh, there's a nice confluence here. So you've got a good, area that you can anastomosis to. It wasn't like so high up here where it's more complicated.
Very cool. Aarti, I have a companion case.
Okay.
Okay, this was a young patient. She had a remote history of gunshot wound to the abdomen. So these clips, suture material is all from that time. But more recently, she was found down in a pool of blood per history. So there was suspicion that there was some kind of altercation, and she was just found down. So this is the initial CT we read in the morning and made few observations.
It looked like a hepatic laceration.
Yeah, definitely. Very jagged margins going close to the portal structures and the hilum. We looked very closely to see if there's any pseudoaneurysm or any venous injury. Didn't really find any. Called a small subcapsular hematoma here. And then we called a little bit of fluid around the gallbladder. We did see a stone somewhere on here, unrelated, but then we did call some of this fluid close to the pylorus of the stomach and fundus of the gallbladder. I don't think surgery did much at this point, but then she kept dropping her H&H, so we repeated a CT a few hours later. And now you can see there's a lot more fluid going along that anterior peritoneum, bathing the transverse colon and hepatic flexure. This subcapsular hematoma increased a little in size. Still no real overt vascular injury. The hepatic laceration remained. So they were not sure what to do. They called an IR consult to see if they would, quote, drain some of this. But then they decided to do an MR. And in contrast to your previous case, I actually wish they had done EOVIST, which they did not. But anyway, here's the FATSAT T2 from the MR. And now you see a whole lot of fluid. And we were a little worried about this part of the gallbladder, the wall of the gallbladder wall itself. And some of this on the pre-T ones was a little bright. And this is where we really wish we had EOVIST. But nevertheless, I think looking at the increasing fluid, we questioned the gallbladder irregularity and actually went back on the CT and found that area is still a little dusky. So we went ahead and actually called this a probable gallbladder perforation with bile and hemorrhage. And that's exactly what they found on surgery. They said the minute they opened the abdomen, there was a gush of bile from the fundus of the gallbladder. So this was one where even though we didn't do UVist, because there was increasing fluid and that little bit of fundal irregularity, prospectively we called and luckily got right.
Great call.
That's amazing. I've never seen a traumatic gall rupture.
Right. So this was all blunt injury. I think it was some kind of domestic altercation type. So she got kicked in the abdomen.
Oh my gosh.
All these are from blunt trauma from a assault type thing. So it's very sad. But she's doing well post chole and repair of. They fulgurated the liver and they did a cholecystectomy. So serial scans, I think, really help. Despite not having UVist, retrospectively, somehow the CT also helped us to put the 2 and 2 together.
We have the opposite problem here where they order too many EOVIS scans.
Well,
like
we
Billy
do
will be
too.
like 10 and they're like, biliary
Agreed.
obstruction,
Right.
need EOVIS. And
Right. That all comes from the hepatologists and the GI folks. And when needed, like the trauma surgeons, they are a little shy to do UVist. So no winning.
yeah, I think it's just about like when people hear biliary, they think EOVIS. And it's like there's two major, there's a huge bifurcation. Like if it's a bile leak, then that helps. And the biliary is not too high. If it's a biliary obstruction, you don't need it and it won't work. So
Correct. And in this case, the confounding thing for us was, is all this fluid coming from the liver lac or from the gallbladder? And really, the UVist would have helped, right? Easily, much more than hedging so much on reporting.
I have a question though, because
Yeah.
the EVIS doesn't always go into the gallbladder. Like, do you know what I mean? Like, say it just went
Right,
down the
right,
biliary
right.
tree, you still might not have the answer.
Well, either way, at least the CT definitely helped, I think.
Yeah.
Yeah.
Good call.
What do you see?
Nothing.
So this is a patient who had a renal transplant. And we got a multiphasic CT.
It looks
Very-
hypovascular.
Tell me. Okay, so that's the venous. So let me give you the arterial. It's right here. Oh, that's not helpful, but here it is. And then here is the pre. I'll give you. Oh no, this is arterial.
Looks like the artery's patent.
Yep. Yes, that's correct. And then here's the
But the
venous.
entire kidney is not enhancing normally.
Okay.
It's like completely dark.
Yes.
It's devascularized.
From.
Mm.
And here we did a dual energy. I don't know if this helps or hurts, but here's your devascularized kidney. Or
What is that curvilinear thing which is looking?
yes, tell me about that curvilinear thing.
Is this the renal vein thrombosis?
And here's the virtual non-con. Excellent. Okay, here's your virtual non-con. And so the vein is here. And they actually did like an extension. So I think they took like the IVC, the donor IVC or iliac vein, and then did an extension because they didn't have enough length. And so here it is.
So acute hyperattenuating thrombus.
Yes, expansile, and it's hyperdense on the virtual non-contrast. They took the patient to the OR, and the allograft kidney was completely ischemic, and so they ended up doing a nephrectomy for renal vein thrombus. This was completely thrombosed.
One
And
interesting finding
it's
in
shown
renal vein
nicely here.
thrombosis on Doppler is a reversal of diastolic flow. I don't know, was Doppler done on this patient?
Yes, it was. And that suspicion was raised on the ultrasound. and I want to show you the ultrasound. Can you pause, please? Okay. So the renal vein was patent intraoperatively. What was occluded was the extending vein.
Oh
That was
yeah, that's like
harvested.
that huge thing there is the
Yes,
IBC extension you're saying.
yes, that was completely occluded. And you can
Oh
see that.
wow.
And it was hyperdense on the virtual non-con, and it
Mhm.
didn't enhance at all. And that was what led to a venous infarction.
Wow. It's interesting. I wonder why they did the venous extension. Do you think it was like a right-sided donor because they have a shorter right renal vein?
That's a good point. Sorry, I didn't look into it, so I don't
No,
know.
no worries. I've just never seen an IVC extension, so it's like, why did they have to do that? But interesting. And then you would think it's such a big vein, like why would that thrombose? But lots of reasons, like prolonged ischemia time. And I had a case of a renal vein thrombosis in immediate post-op, but they were able to take the patient back to the OR, evacuate the thrombus, and save the kidney. So that's one thing that I'm always like really cognizant of, like on the immediate post-op, we're clearing the vessels, but like if they are on ice for too long, prolonged ischemia time, they're more prone to getting like sluggish flow and then that renal vein thrombosis.
I do know which kidney was harvested, the right kidney, the donor right kidney.
Okay. Yeah.
So that is
makes a
shorter
little bit more
than
sense,
the.
yeah.
Mhm.
Which is why they usually like to take the left side because it has a longer pedicle.
Aarti, I have a companion case to show.
Sure.
So young patient with history of hematuria and abdominal pain. I'm just going to scroll through the relevant images back and forth.
There's some like tubular fluid filled stuff anterior to the pancreas between the stomach and the pancreas.
Yes. So she had ongoing pancreatitis, so that was a known peripancreatic collection. Look at the vascular structures. Show you a sagittal. And then back to axial. What do you guys think of the left renal vein?
Looks like it's filling early or it's
Like a
distended.
nutcracker?
Yeah, caliber.
Yeah.
So dilated here and then suddenly narrows. And then on the sagittal, that SMA to aorta angle is very shallow. Typically, it should be, I think, 45 degrees.
The lumbar veins dilated? Looks like they are, maybe.
They are,
Gonadal
yeah.
veins.
So yes, the gonadal veins were as a compensation or reflux, I guess. Interestingly, this patient then went on to get what they call an auto-renal transplant, where they moved the left kidney to the right lower quadrant. So this is her native left kidney, which is now in the right renal fossa. So this is a more recent exam. Didn't know what to call these wedge-shaped hypodensities.
Sorry,
In native,
what led to that? Was there like why did they do that? I mean, was it renal
for
function
the
deterioration?
Nutcracker, I suppose.
I was gonna say usually for Nutcracker, they just move the
Yeah,
vein like over the SMA.
Yeah, I don't know why this one they moved it.
She also like maybe she had May Thurner too because she
Yeah,
had
there's a stent, which is, presumed to
just a
be
lot of stuff.
from May Turner. But then she came with this finding in this newly moved kidney. So in native kidneys, we always say if you have the rim sign, that doesn't mean that means there is still preserved cortical flow. I quite didn't know when you move the kidney like this, what happens to that. So we gave a differential. Could this be infarct or pyelo? She did not have a white count. Her WBC, her urine was not that bad. I presume this is still some sort of infarct. But had not seen this before where they moved the whole kidney for a Nutcracker to a separate quadrant.
She seems
Her
she doesn't have a lot
BMI
of
is so low.
internal.
Yeah, her BMI is 13. She's like 25 years old and BMI is 13. They've put a feeding tube now for her nutritional.
Yeah, I was gonna say Maybe there wasn't enough room to like move the
Probably.
and,
Yeah, because of the scaphoid body habitus.
and she's having all these other compression things like Turner and everything.
Yeah.
Interesting. Also, what you're saying about the capsular artery, that's interesting because, like, yeah, things change when you have a transplant, right? Because you're disconnecting them from all the peripheral stuff. And I think about that with like liver transplants. Like, people ask, like, why are they so much more susceptible to biliary ischemia if the hepatic artery goes down, when sometimes we deliberately do TACE of a hepatic artery and things like that. But I think part of it is they don't have that third inflow because you're like disconnecting them from all these external input. This one is not something I would ever diagnose, but just wanted to show it to you because it was the first time I'd heard of this entity. So there's ascites, and there's basically like peritoneal carcinomatosis look. We're like, okay, there's peritoneal disease. Is the pancreas okay? Is the stomach okay? Everything looked okay. Male patient, they also have HIV. They went and sampled, actually, they did have some big lymph nodes down here. So they went and sampled one of these lymph nodes, and it came back like kind of like reactive to HIV, like it wasn't anything specific. And then they sampled this fluid, and let me just get my notes because it was something.
Was he recently started on an antiretroviral therapy? Was that a flare?
Nope. The path from the effusion came back abundant large malignant cells with high nuclear to cellular ratio and pleomorphic nuclei, findings compatible with primary effusion lymphoma.
What?
Yep. So I'm going to bring over, it was in Radiopedia. It's not so rare that it's not here. So anyway, there's something called primary effusion lymphoma, where it's a rare form, it's aggressive, and it's basically malignant fluid accumulation without lymphadenopathy. So I think the lymph nodes that we saw here were related to his HIV, but they weren't actually lymphoma. These you will see like a pleural effusion, pericardial or peritoneal fluid, and the fluid will actually have all these malignant cells in them. So it's not like a reactive ascites or anything like that. Like, this stuff is the lymphoma. And there were abundant malignant cells in here.
Wow.
Yeah. So it's just something new. And then the happy part of the story is they got a bone marrow transplant and chemotherapy, and it's all gone.
That's good. It behaves like lymphoma elsewhere, right?
Yep. Mm-hmm. Yeah.
Did they get a pet?
Let me see. We did multiple, so let me try to find the appropriate one. You want to see if the ascites was
Yes.
hot? Okay. No promises here, but hold on. Oh, this is after. Oh. We don't have any pet when they had we only have after it's gone. Sorry.
Aarti, would you have ever questioned a peritoneal like a primary peritoneal malignancy, because we didn't see any of the usual suspects?
I don't usually bring up primary peritoneal disease.
I mean, immunosuppressed patient,
Yeah.
weird looking nodular.
Yeah, I mean, so the two interesting things is that they were HIV positive and also HHV-8 positive. And those are the two things that are majorly associated with this primary effusion lymphoma. But I think it's so rare, I don't think I would have brought it up. I think I would have just said like peritoneal disease of unknown primary, like maybe check the lungs, check like their neck. I don't know. I think it's probably like still a path diagnosis, but I do think in that other case with the osteopetrosis, like now that I know about that association with the extramedullary hematopoiesis, like if that ever comes up again, I would like to be like, yeah, that retroperitoneal mass is definitely extramedullary hematopoiesis, but I feel like this one is too nonspecific.
If they're in the Southwest, cocci can also look like that.
Yes, and TB also, right?
Yeah.
Yeah. So I think I might have even brought up, that kind of stuff, like, oh, this could be infectious or.
Okay, Aarti, I can do a quick show and tell.
Okay, great.
Okay, so this is like a 70-year-old guy with anal cancer. He's been treated. He has, as you can obviously see, he has something going on at the surgical site, which is measured here. But this is more of a, can you see something else? And what do you think? So I'm going to scroll down, okay? And let me know if you'll see something else. It's just, like I said, it's a show and tell thing. I didn't know about it. So
There's a flap. Or sorry, go ahead.
yeah, there's a flap here. That's agreed. Something else on this image and maybe upcoming images.
There's
I'm going to show it.
Wait,
show
there's
this.
like some kind of tubular thing next to their muscle?
Yes. Thoughts?
You mean the left medial thigh?
Mm-hmm.
They didn't move their testicle down there, right?
They did. So that's what it is. I had not seen it along the medial side there. And on the right side, it is here.
Oh yeah, you can follow that. Look at that. Look
Yeah.
at the vessels.
So it's here on the right side and it's here on the left. And
Wait, because the radiation to get it out of the radiation field, or
no,
what?
I don't know the cause in this case, possibly because of that, but in general, and that's why we pulled it up and we were looking at when they do it, and we found an article where they actually do a temporary relocation of the testes in the anteromedial thigh, typically when the patient has Fournier's gangrene with extensive loss of scrotal skin. So that was the only one that I found. I did not find anything about radiation therapy needing to, in fact, we didn't get any history of this procedure at all. We just incidentally saw it and we were kind of wondering what it is, but it did look very much like the testes. So then we looked up and you can trace all the vessels and everything. Same on the right side. So it was just something that
That's cool. That's like the
I had.
ovarian transposition that they do.
Yeah, exactly. Like when they hitch the ovaries up along the lateral abdominal wall, something similar for the testes. Just something I hadn't seen, so I thought it would be a cool one to show.
Nice.
Has any of you all seen any cases like this?
Nope.
Nope.
I've seen 3 testicles. Supernumerary testicles.
What?
Yeah.
Where was the third one?
No, it was on the same ipsilateral side.
Oh, like 2 on one side and then 1 on
Yes. Yes.
I've seen 3 kidneys.
Oh wow.
Yeah, you can have up to 4.
Oh really?
Yeah, because each side has 2 nephrogenic buds that fuse, which is why sometimes you can get a duplicated kidney on each, like a duplex kidney. So anyway, there's 4 buds and then 2 fuse on each side and then rise up out of the pelvis. So you can get all sorts of cross anomalies, but you can get 4 kidneys if the 2 don't fuse.
I can see education exhibits on duplicated organs.
Yeah, and you can have supernumerary nipples.
Right.
I know somebody that has some. They're in a line.
Wait, like a real person or a case?
Yeah. No, person.
Oh, wow. What an interesting to know about someone.
Yeah, well, they showed us in medical school.
Oh, is this being recorded?
Yes.
This was a pre-TAVR CT. And so it's kind of preoperative planning, but there's incidental findings that are significant.
Something in the mesentery, Nelly.
Yes, yes, right there, right? Is that what you're referring to?
Mhm.
Good. Okay, there's more.
So I see additional nodes.
Yes. I don't know if this is helping or hurting, but
Like a carcinoid or something.
Yeah.
yeah, exactly. And actually, if you're kind of like awake and on it, you can maybe kind of hallucinate something there. And so yes, so all these things were unexpected. And I'm gonna share with you the dotatate that outlines the multifocal nature of this. Uh, okay. So that mesenteric node was here, Rupa, lots of them, right? Multiple. And in addition, there's multifocal ileal carcinoids. It's kind of hard to
Which
appreciate the
actually
full.
is the most common pattern where
Yep.
like there's lots of little ones. And I was like, my surgeons were telling me that like basically when they go to the OR, they palpate the bowel and feel all these little nubbins. And then like they until they stop feeling the nubbins, that's basically how they resect. Like, and then they showed me a specimen opened up and there were like all these little tiny nodules.
And I think dotatate can complement the surgical approach, to really help them localize the location and number so that you can have a complete
I
resection.
asked them about that and they said
Yeah.
they're like, we have a better imaging study, which is our fingers.
How do you look for nodes though? Like how do you, right, to
Oh, I
evaluate
mean,
the
they're going to
extent of
resect all
nodes?
those nodes, but the major thing that we use dotatate, I mean, that has been like game changer is like the extent of liver disease, but also bone mets, which I feel are really poorly seen on CT and MR. And so we've
100%.
seen a lot of cases where there's actually bone mets on dotatate that like we're not seeing at all on the other studies.
Agreed, Aarti. That's what one of our surgeons said is don't worry about not finding the primary because it's so small. We rely on palpation. They just want to know the extra nodal and like, is there liver disease? Is there systemic disease?
Kind of like endometriosis, they'll see all the small stuff, but they want to know the big stuff that are not in the operative field.
Yep. If I had a neuroendocrine, I would like really advocate for a dotatate.
Oh, 100%.
Cool. Okay.
So that's a Doppler spectrum from transplant kidney, and that's the waveform that I was talking about. So it should go sharp upstroke and it should be always forward and forward flow. But this is going below the baseline. So this is reversal of diastolic flow. So each time we see that, it is ominous, and we have to look for couple of things which are responsible for this. And one of the classic things is either perinephric hematoma post-transplant, also known as page kidney. It can also be because of renal vein thrombosis. So that's why when Dr. Tan showed the case, I was like, does that patient have a reversed diastolic flow? This patient had a perinephric hematoma.
Nishant, actually in your ultrasound, the velocity of that artery was 387 or 383. Why do you think it was so high? Oh, is it like the hematoma was even like compressing the artery? So then there was like a gush of flow right through there?
Possible.
Okay. But then also it was compressing the kidney. So then there was high resistance, like reversal of flow.
Yes.
Okay.
Exactly.
We've got like some combined features here of like a stenosis, but also high resistance. Got it.
Yes.
Sorry, you were showing the CT and I interrupted you. Sorry.
So the huge perinephric hematoma.
Yeah, page kidney.
So
Did they evacuate it?
Evacuate it?
Yes. They went inside and removed it.
Yeah. Yeah, I mean, that's subcapsular, so it's really going to put a lot of pressure on the kidney. If it's perinephric, like around the kidney, sometimes, you know, they'll wait and see how the creatinine does.
That's about it.
Cool. This is the finding.
Do you have the sagittal?
Is that in like around the cervix? No.
Inside.
Yes.
It's like some kind of,
Some form of contraception device.
yeah.
Yeah, yeah, it's an IUD, and I had never seen one like that look like a ring like this. And this one, I'll pull up my article here, is called a Chinese ring. It was common in the 80s and 90s when China had the one child policy. It actually looks like kind of like this little spring. It doesn't have a string on it, so it's considered a permanent IUD, and it's really hard to remove. So yeah, that was one of the reasons that they used it. And it was placed immediately after childbirth.
Optionally? Who
Who
knows?
knows? But yes, it's challenging to remove.
So this was a young female with rectal cancer, and it was treated by radiotherapy. So both the ovaries were transpositioned, as Dr. Jambhekar mentioned. So that's the ovary cystic structure, multicystic structure, but we see the gonadal vessels going through, and we see the surgical clip.
Nice. Yeah. So I've seen them do this for cervical cancer and sometimes for rectal cancer. Those are the main indications, right? If they're going to do radiation.
Yes.
Get out of the field of view. Nice.
So this is a young male in late 20s and comes with shortness of breath since a long time. And what I want you to focus on is the lung basis. And these findings have been there since at least a couple of years, say 2 or 3 years. So this is non-specific reticulation, and it's more common, it's present predominantly in the lower areas and peripheral areas. So this is a NSIP, non-specific interstitial pneumonia pattern. And whenever seen, we have to look for a secondary cause because NSIP pattern is rarely idiopathic. So this guy also had something, but let me show you his soft tissue window and I will have you see that. Look at the muscles. He's a young male, late 20s.
Very atrophied, Yashan.
The right side.
Yeah,
Especially.
like a lot of fatty atrophy.
Fatty liver too. I don't know if that's part of it.
Yeah, pancreas is also a little.
I think pancreas may be unrelated, but yeah, a lot of atrophy of the psoas and even other muscles. So, I mean, before telling what it is, the bottom line is anytime we see NSIP, always think of something secondary causing it, more so connective tissue disorder, regardless of the gender. This is a male patient, or it could be also drugs which can cause the NSIP pattern. So this patient had immune-mediated necrotizing myopathy, and that is in response to production of an antibody to a weird agent, which I did not know. I'm pulling that up. So he had antibodies to SRP, and that can give rise to interstitial lung disease as well as myopathy.
Wow.
S-
Can you scroll down? So basically, just randomly, you make an autoimmune disease with the antibodies, and it leads to myopathy and lung disease.
Mhm.
Got it.
I mean, it's not
Nishant, what is SRP?
SRP is signal related peptides or signal related proteins.
Gotcha. Okay. Wow.
Signal recognition particle.
You should upload that case to Radiopedia so that now they have a case associated with it.
Yeah, good idea.
Yes, absolutely. The other teaching point that I wanted to mention here was like, even scleroderma does show ILD. Rarely it can show myopathy in combination with sclerositis, which is an overlap syndrome of scleroderma with either dermatomyositis or scleroderma with polymyositis. One reason that it is not favored to be scleroderma on imaging is because esophagus is fine here.
Presumably, they would also have like more specific rheumatologic, tests for it, or no?
I mean, they run a panel of tests, including the more common ones like double-stranded DNA and ANA. And I don't know, depending on like what the predominant symptom is, they would run probably specific set of antibodies, autoantibodies. I mean, I'm not sure, but they do definitely run a set of common autoantigens first.
Is it treatable?
The patient is on rituximab, so I think more or less all these drugs disorders are treated similarly.
Well, thank you.
Sorry, I don't have much information.
No,
about-
no, no. You always have these great.
Another first.
Yeah, exactly.
And no, I love that idea of like sending it to those guys, so at least wider population sees it.
I'm hoping to upload a lot to Radiopedia. My colleague Stefan Tigges is always telling me to do that. So one day soon when I have some free time. But I think it's such a great resource, right? Because it's just like,
I love Radiopedia.
yeah. It's all of us collaborating to keep things up to date. Okay, if that's it, I'll see you guys later.
Thanks all.
Bye.